Howdy, y'all. I'm Dr. Jeff Jarvis, and I want to review our delayed sequence intubation protocol with you. Now, this protocol review module is just going to primarily focus on the protocol itself. And the reason is because we got separate videos that go over the science behind why we're doing what we're doing and how to run through the specific protocol and checklist. Now, one thing to make clear is the context for the protocol. This entire protocol is only for those patients not in cardiac arrest. To be clear, the protocol doesn't address cardiac arrest at all, other than maybe how to avoid causing it. We're only talking about patients not in cardiac arrest. Patients who were in cardiac arrest but have successfully been resuscitated, they can be intubated, but only with DSI. Our approach to intubation has historically been with ketamine only, meaning no paralytic. And our first pass success rate, despite adopting video laryngoscopy, has been unacceptably low.
I can't watch this anymore.
Now, I think we can always improve with more training, maybe new technique, maybe a new device or blade shape. But I think the biggest reason we are failing was because we, and by we I mean me, were asking you to intubate with one hand tied behind your back. Intubating without a paralytic, it's just harder than intubating with one. I certainly wouldn't dream of trying to intubate without sedation and paralysis, so I shouldn't be asking you to either. Turns out humans have evolved to prevent things from crawling into our tracheas, whether it's a furry, cute little critter or a piece of plastic. As a species, we kind of suck at a lot of things, but this ain't one of them. Even when we are deeply sedated, our airway reflexes are typically very effective at making intubation difficult. That's the whole reason for paralyzing someone to begin with. I'm not surprised we don't have great intubation rates because we haven't given you the right tools. We changed that though with this protocol. The goal is to give you the tools you need to do the job right. Now, I also think it is worth going over my philosophy about intubation, and there are really just two rules for that. Rule number one, this is about the patient. It's not about our ego. Everything else follows rule number one. Rule number two, if we're going to intubate, we must do it right. If we can't do it right, we're not going to do it at all. And doing it right means following this protocol for any patient who is not in cardiac arrest at the time of intubation. This is the only way I am authorizing intubation of these non-cardiac arrest patients. Now, additionally, there will be no intubations outside of cardiac arrest without DSI. To put that another way, we do DSI or we don't intubate. Hopefully I've made that clear. Now, guys, y'all know me. I joke about a lot of things, but this isn't one of them. I am very, very serious about this. We will do this right, meaning this way, or we will not do it at all. It's not what's in the patient's best interest. Now, it is probably worth focusing on what our aim is with this protocol. We want to maximize first pass success without hypoxia or hypotension. That's the measure we're looking at to determine if we're doing intubation right and whether we will continue to do it at all. Remember, it's about the patient, not about us. Now, we know first pass success is associated with fewer adverse events than even one missed intubation. Now, the most common adverse events are hypoxia and hypotension. Works kind of like this. Hypoxia leads to bradycardia. Bradycardia leads to hypotension. Hypotension leads to cardiac arrest. These are all bad. About 45% of all EMS intubations are associated with peri-intubation hypoxia. About 15 to 20% are associated with hypotension, and 2 to 3% are associated with peri-intubation cardiac arrest, meaning we weren't intubating them because of cardiac arrest. They went into cardiac arrest because of the way we intubated them. Now, this DSI protocol is specifically developed to address these things. Now, let's get to the protocol itself. First thing is that you're going to note that the checklist is mandatory for all DSIs. Regardless of how much experience you have, you still must use the checklist. I want to be very clear, must use the checklist. Levi, are you pretty clear on that? Do we have to use the checklist?
I think so.
We got to use the checklist. Good. So, when I'm thinking about checklist, I think about an experience I had with my brother-in-law, Howard. So let me tell you about this. Howard is a great pilot. He spent his entire life flying. He flew B-52s in the Air Force and then moved to 737s, 747s, 777s as a captain for commercial airlines. To say the least, he is an experienced pilot. So I was flying with him a few years ago, and as we're going along, I said, "Hey, Howard, what would you do if we lost power right now in our single-engine aircraft?" And he said, "Well, I'm going to hand you this lost power checklist, and we would run the thing together." I said, "It doesn't really seem like we have time to use a checklist because, we're like plummeting to the planet and all, and that seems eminently bad." And what he told me stuck with me. He said, "Jeff, I don't have time not to use the checklist. Missing something on that list would be bad, bad, bad. And second, it would end up taking more time. And when it comes to intubation, remember, we don't have time not to use the checklist." So Howard, thank you. Basic interventions, these are aimed at setting the patient in the environment up for a successful intubation on first pass without hypoxia or hypotension. Remember, that's our goal. This is very important. The setup is key to doing it right. Now, we have to have full monitoring, including blood pressure, ECG, end-tidal CO2, and pulse ox. One thing, please make sure that the pulse ox probe is not on the same arm as the blood pressure cuff. This happens all the time in and out of the hospital. Remember that pulse oximetry requires a pulse, and blood pressure cuffs, those transiently cut off pulses distal to the cuff, so make sure that's not where the probe sensor thingy is. We also want to make sure that we have placed apneic oxygenation on the patient, raised the head of the bed, put them in intersternal notch, and everything is ready for max BVM. One comment about nasal cannula oxygen, we are really big advocates, as I know y'all all know, of end-tidal CO2, but remember that just because you can run oxygen through the end-tidal CO2 probe doesn't mean that it's good for it. At best, you get about 20% of the oxygen flow through the oxygen port on the end-tidal CO2 that you do if you're using a real one. So please use the real one. Now at the ALS level, make sure you have IV access or IO access and have a very low threshold for pre-mixing push-dose epi, even if they're not hypotensive. If you have a whiff of a hint that they might become hypotensive, go ahead and mix it up. Now, I'm not saying you have to mix it up. I'm not saying you gotta break open the epi. I'm just saying have it out, have it at hand, make sure you're ready to mix it if needed. Now you're going to note this protocol looks a bit odd because there are 2 ALS sections in the document. We did this because we're not making any changes to the credential level that can do the intubation. What we're doing is adding restrictions on which patients can be intubated regardless of who's doing the intubation. Now ALS continues to be credentialed for intubation, and likewise EMTs will continue to be credentialed for supraglottic airway insertion. So with that out of the way, let's get into the meat of the protocol. So DSI is intended to slow things down. It will take longer. Guys, to me, this is not a bug, it's a feature. It is my intention. I know it's going to take longer. Now, if you as the treating clinician feel the patient doesn't have the time to properly prepare for intubation, no worries, it's okay. Get on the road, get off the scene, just don't intubate. Only intubate if you can do it right. See rule number 2. And I understand doing it right can take a bit more time. Now, as a bit of foreshadowing, because I can hear you out there right now, but Dr. Jarvis, what if I don't have time and I have to control the airway? Well, we have another protocol for that. That is the RSA, or Rapid Sequence Airway Protocol. That protocol allows for what is essentially traditional RSI, but with a supraglottic airway. If you don't have time for DSI, then do RSA. So just place the supraglottic instead of intubate. And if you need a paralytic to properly place the supraglottic, that's okay. That's included in the protocol also. But we'll talk more about that with a future PRM. Now, the intent of this delay, hence delayed sequence, is to allow us to properly prepare the patient's physiology for intubation by adequately pre-oxygenating, denitrogenating, and dealing with their blood pressure. So this frequently requires that the patient be sedated first. We'll give ketamine to do this and then allow us to better prepare them. You can see what the typical timeline of a DSI looks like in the graphic at the bottom of the protocol. So get everything ready, then give the patient ketamine. And please note that you do not have to have achieved any particular saturation to give the ketamine. You may notice this is a change from our prior DAA protocol, and absolutely it is. The reason for the change is often the patient won't tolerate you doing the things you need to do to get those sats up. Ketamine helps you properly pre-oxygenate them. It greatly increases the odds of successful pre-oxygenation and safe intubation. And remember, we're doing this for the patients. We're not doing this to hurt them. Now, once you've achieved an SpO2 of 94% or higher, so that's greater than or equal to 94, start a stopwatch, and I literally mean a stopwatch. Use the timer that we're providing for this purpose. It's not that I don't trust y'all, but I don't trust my perception of time when I'm intubating, and no offense, but I don't trust yours either. It's your perception of time that I don't trust, and that's because you're human. We're all human, and time is relative when we're in a high-stress situation, like, say, intubating. So to help with this, you need to designate a safety officer of sorts. This is somebody who's dedicated to watching the monitor during the procedure and watching that time. It's their job to let you know when the sats drop below 94% and tell you to abort. If they tell you to abort, I don't care who you are, you must abort. If I'm the one on scene doing the intubation and one of you tells me to abort, I don't care if you're a paramedic, an EMT, an ECA, you tell me to abort, I'm aborting, because rule number one.
That's an order.
Now, we're only going to give rocuronium after we've maintained continuous saturations at or above 94 for 3 continuous minutes. If the sats drop below 94, reposition, increase your PEEP, do whatever else you need to do to get the sats back up, and then restart your clock. That's 3 continuous minutes. We must also assure that the blood pressure, the systolic blood pressure, is above 100. If it's below this level, resuscitate them before you intubate them. Give them fluids, give them push-dose epi, give them Levofed. Your judgment will dictate which approach to use, but remember the advantage of push-dose epi is that it can be given faster and has a faster impact than the other approaches. But it doesn't take very long. So if you need to use push dose, go for it, man. Use that push dose, but you probably ought to get the norepi drip ready. The goal for proceeding with the intubation, though, is a systolic above 100. Also pay attention to the shock index. Shock index is heart rate divided by systolic blood pressure. If it is above 1, meaning, I'm an Aggie, don't do math in my head real quick, a shock index of greater than 1 means the heart rate is greater than the blood pressure. If they have a shock index greater than 1, they're at a high risk of dropping their pressure, even if they aren't currently hypotensive. So definitely get everything ready to raise that blood pressure, even if they're not currently hypotensive. Now, after we've met our pre-oxygenation and blood pressure goals, go ahead and give the rocuronium. But understand that it doesn't take effect immediately. About 50% of the population will have pretty good intubating conditions after about 45 seconds. But we're not looking to flip a coin about whether the patient is ready for intubation or not. We are going to wait 90 seconds, restart the stopwatch, restart that timer, make sure there's been 90 seconds, and then assuming the pulse ox and blood pressure goals have been continuously met, go ahead and proceed with the intubation. Now, I want y'all to know I am deadly serious about this, y'all. Do not, under any circumstances, proceed with intubation if you haven't had continuous sats at or above 94% and the blood pressure is above 100. You may not be able to achieve these things, and there's no shame in that. If it happens, just move on to RSA and supraglottic. If the patient desaturates during your intubation after you've met those goals, again, no worries, just abort. Bag them up, and after you achieve 3 minutes of adequate sats, you can try again. Maximum number of attempts is 2, though. That's 2 attempts per patient, not per clinician. So this protocol allows you to safely and successfully intubate the patient, focuses on safety. Please, please follow this protocol because this is about the patient and it is the right way to intubate safely. Again, no worries if you have to abort the attempt because you're doing the right thing for the patient. On the other hand, if you intentionally decide to give rock or intubate despite not meeting these goals, I will have no choice but to consider this an intentional, deliberate access, and I'm not going to tolerate it. Remember rule number 1, y'all. This is about the patient, not our ego. I have to be very clear about my expectations here, but fortunately, I have faith in your ability as clinicians, and I trust you, but I'm trusting you to work within this framework. I'm begging you, please don't test me on this. All right, guys, that's the meat of the protocol. Follow that checklist because remember, it's mandatory. Remember Howard. Give the ketamine to help you achieve your physiologic goals. Give rock once these goals have been met, and then intubate. Don't skip steps because those steps are not optional. This is one of those rare protocols that are linear and must be done in order. As a reminder, our physiologic goals are pretty simple. SpO2 at or above 94 continuously for at least 3 minutes, and SBP, systolic blood pressure, is greater than or equal to 100. If you can't meet these goals despite ketamine and all of the preparatory steps, no worries, but do not attempt intubation. Move on to rapid sequence airway.
Do not pass go. Do not collect $200.
So that's the DSI protocol. I want y'all to know this protocol has been tested in the field. We implemented it in my prior systems and we saw our peri-intubation rate drop from 44% to 3%. Since then, it's been validated in several additional systems. It works. I trust y'all and I know that we're going to see the same success here. It's based on good science, it works, and I think it's the right thing to do for our patients. All right, I'm going to wrap up with a couple of questions I frequently get when I talk about DSI, and boy, do I like to talk about DSI. So question number 1, when should I actively bag the patient as opposed to supporting spontaneous respirations using a max BVM? Well, as long as the patient is adequately breathing, let him keep on doing it. Remember, ketamine in the vast majority of patients doesn't inhibit airway reflexes or depress respiratory drive. It's the whole benefit of ketamine. Now, as you learned or will learn in the videos on the science behind this process, using non-invasive positive pressure ventilation in addition to nasal cannula is the most effective way of achieving complete denitrogenation that we have. It is definitely more effective than a non-rebreather. That's why we're using a BVM with a tight seal to provide oxygen. Now, not all BVMs deliver oxygen without squeezing the bag, but all of them will do it when they're used with a PEEP valve. It allows the patient to continue spontaneously breathing while replacing all of that worthless nitrogen with some good homegrown mother-approved oxygen. It is good stuff. If we had ventilators with BiPAP on all of our units, by the way, we'd allow that as well. But we don't, so we're going to use BVM, max BVM, with a nasal cannula and PEEP. This is basically the same approach that our anesthesiology colleagues use in the OR. They just have some cooler bags. Not that I'm jealous or anything. So if the patient needs assisted ventilation, give it to them. Remember that ketamine is really pretty good. Vast majority of patients will not have any respiratory depression, but the vast majority is not all. Some will, and if they do, just go right ahead with assisting their ventilation. Now, it's also more likely you're going to need to assist their ventilations the closer and closer to 90 seconds after you've given that paralytic you get. It's all right to gently bag them as long as you're ready for it, and of course you will be. So another question comes up a lot: what should I do if I can't get the sats up despite all the things? Well, first, make sure you really are doing all the things. So remember max BVM, we need to have the head of the bed elevated. We need to make sure that the patient is in ear to sternal notch position. We need to make sure you're using the real nasal cannula set at maximum liter flow, not that end-tidal CO2 thingy. Use that for end-tidal CO2, not for oxygen. Make sure you have a good two-handed mask seal. Put in some nasal airways. Remember, these guys are going to have already had ketamine. Your BVM must also be set at the maximum oxygen flow. Check all this. And if you check all that and you still aren't getting the saturations up, start titrating your PEEP upwards. This should do it for the vast majority of patients. If it doesn't, if that still doesn't work, sats still aren't coming up, abort and move on to RSA. So I frequently get the question, how many intubation attempts do we get? Remember, 2. That's 2 per patient, not per medic. Again, remember, the number shall be 2. 2 shall be the number shall not be 3.
Amen.
Amen.
Hopefully that's clear. What about drug dosages? What are our drug dosages? For ketamine, same dose, now 2 milligrams per kilogram IV or IO. If you need to repeat it, go for it, but do it once. If you've given 4 milligrams per kilogram of IV ketamine and it's not working, more is probably not going to. You have to ask why. Is that IV really patent? Are you giving it subcutaneously instead of IV? Make sure you troubleshoot that. If you've done everything right, make sure that it's not just an issue of their eyes being open, because ketamine's that weird drug. They may be completely out of it, but their eyes are still open. All right, remember with ketamine, max single dose, 200 milligrams. Rocuronium, we're going on the high side, use 1.5 milligrams per kilogram IV or IO. Now you may notice that there are no IM doses. If they don't have an IV or an IO, you are not authorized to do DSI. Move on down the road, get the IO or place an iGel. All right, so who can perform intubation, the actual intubation? Well, that hasn't changed. Intubation is still at the ALS credential level. That's the credential level formerly known as assist. Well, I know you said 3 minutes, but what if I just have one dropped sat during pre-ox? Reset the 3-minute time clock. Do not proceed without 3 minutes of continuous sats at or above 94. I'm repeating myself, but hopefully I'm clear. All right, I love this question. Why are you being such a hard ass about complying with this protocol? Okay, number one, C rule number one. This is about the patient. The use of paralytics is kind of a big deal and it can cause harm. We are taking away our patient's ability to breathe. We have to be able to manage their airway, and we need to take it very seriously and do everything we can to use these tools safely. Now, I'm comfortable with you all using them because I trust you will follow this protocol that is designed to maximize safety. Again, remember rule number one, it's about the patient. And remember rule number two, we either do it right or we don't do it. All right, another question, is there anything different about what we do after we successfully place the tube? Yes, and it turns out there's a protocol for that. Awareness after paralysis is a very real thing. It's been documented in up to 5% of patients undergoing RSI in the emergency department, and the likelihood of awareness is more than twice as likely when giving longer lasting paralytics like rocuronium. So to avoid this, I want y'all to redose the patient with another 2 milligrams per kilogram of ketamine as soon as you have everything secured. More on this in the post-intubation management PRM. Now, I'm sure y'all may have some other questions, and as always, I'd love to answer them. I'd love to address any concerns y'all have. Drop me an email or come on by. Thanks, y'all. I really do appreciate what you're doing. I believe in you, and I want to give you the tools to do the best you can for your patients. I want you to succeed in that, and this is the whole reason for the protocol. Thanks a lot, guys. Take care.